the pathology of the esophagus. Now we are, if you remember in the last lectures about the esophagus, we took the congenital anomalies, we took the foreign body, we took the diverticulum of the esophagus, and also beside that we have today to discuss what we call the hiatal hernia. We have three types of the hiatal hernia. The most common type we have what we call the sliding hernia. This is represented about 85% of the hiatal hernia. And we have a rolling type represented at 5%, and we have a mixed type between sliding and rolling. It is at 10%. This is what we mean by the sliding hernia, what we mean by the rolling type. The sliding type, if you see the pictures on the left side, it is a normal esophagus. We have the cardia below the abdominal diaphragm. There is a 2 to 3 centimeter of the esophagus in the abdominal part, in the abdominal part, in the abdominal part. And in the case of the sliding hernia, the cardia it will be coming up to the chest, to the chest, to the chest with part of the stomach. And in the case of the paraesophageal, we have the cardia still inside the abdominal cavity, but part of the stomach is going to the chest, like the greater curvature of the stomach. Now, what is the sliding hernia? Sliding hernia is a factor that a cause of this. First of all, you should know the sliding hernia, it is a non-true hernia. What we mean by true hernia or non-true hernia, if we have any peritoneal with them, we call it this is a true hernia. If there is no peritoneum with them, we call it this is a non-true hernia. What is the factor that lead to the hiatal hernia? First of all, you should remember it. It is a muscle degeneration, because if you remember what we have, the cardia, it is fixed in its part by many factors. Many factors. One of these factors will be affected when it is by the muscle degeneration by increasing in the age. And when you are growing in your age, all the fiber of the muscles may be changed to the fatty one, especially in the female. Second one, when there is an increase with intra-abdominal pressure, in which cases we have, like a repeated of the pregnancy all the time, it is an increase in the size of the abdomen, increase the size of the pressure inside the abdomen. Besides that, if we have ascites, also it will be increase the abdominal pressure. Also in the male, when it is a prostatic hypertrophy, it will have difficulty in defecation. It leads to the pressure on the abdominal, and also it will be increase the incidence of the hiatal hernia. By the time, the obesity, also it is a good factor to lead to the sliding hernia. It will be changed all the muscle fiber to the fat fibers. These are fat tissue that leads to the losing of the cardia. And lastly, it is when we have a reflux esophagitis lead to the short esophagus, and it will be pull of the cardia to the chest. The clinical feature of that one, it is a female in 40 years above, similar to reflux esophagitis. And here you can differentiate it between reflux esophagitis and hiatal hernia. Maybe it is a part of the reflux esophagitis we have hiatal hernia, or maybe it is only per se it is a hiatal hernia. What is the complication of that one? Lead to the esophagitis. When you have an esophagitis because of the repeated secretion of the acidity to the lower part of the esophagus, lead to the anemia, and later on lead to the stricture. Because of that one, maybe you have inhalation pneumonia, and maybe you have an obstruction of strangulation, that part of the stomach. How we can diagnose of that one, hiatal hernia? By barium study and endoscopy. The treatment of this hiatal hernia previously, in 1980 till this 20th century, we were treated by surgical treatment. surgical treatment. There is no place for medical one because of the development of the PPI. This is a proton pump inhibitors and increase the curity of this sliding hernia and decrease the symptoms of the hiatal hernia, so that it will be a limited space for us to do a surgical intervention. So now it is most likely of these about 80% to 90% they treated by medically, and only 10 to 20% maybe they need a surgical intervention when it is a complaining still. Beside a proper medical treatment for a proper time, still the patient is complaining, there it will be our place to do a surgery for them. This is a photo. You can see the hiatal hernia, how it will be appear, part of the cardia, it will become up. Part of it will become up. Here the mixed type between the hiatal hernia, a rolling and sliding one. Now, second type, it is a rolling one, what we call the paraesophageal hiatal hernia. It is a hernia which is a greater curvature of the stomach is come to the chest, still the cardia inside abdominal cavity. This is a pure rolling. It is a rare. Always it is a combination between sliding and rolling one. We have a more common that we mentioned, it is a 10%. It is a 5%. It is a very rare. We have only a rolling one. This is occur in the elderly patient. But if you remember in the sliding one, it is a young age in 40, and middle age. Here in old age it occur. And this is lead to the reflux esophagitis. And this patient have intermittent dysphagia, and not always you have a dysphagia. Intermittent, every other time have dysphagia, and because of the part of the stomach coming to the chest and compressed on the heart, may be presented of a cardiac symptoms like pressure in the area, have a dyspnea and chest pain during the eating, especially if have heavy meal, and lastly there is an occasionally bouts of hiccup. تلقى لك بين فترة وفترة المريض يصير عنده الهiccup مالته not always. This is if you put it in your mind, maybe this is a rolling type if these symptoms occur in the old age. And it will be increased the complication of that when the patient is in a prone position, and this is especially when he lay down. The complication of that one, because it is a part of the stomach, it's come to the chest, and the orifice is so tight, it will be lead to the strangulated of blood vessels, maybe lead to the volvulus or gangrene of that part of the stomach. So in these cases, to confirm your diagnosis by chest X-ray, you see mass and behind the sternum. It is a widening area, and by endoscopy and barium study, and there is no place here. In this case, in the rolling paraesophageal hernia, there is no role of the medical part. It is always a surgical part. Surgical part are either we can do it by the left thoracotomy or we can do it by laparotomy. What is the factor that affected lower esophageal sphincter to keep inside? This is very important to remember. As we remember, there's a 2 to 3 centimeters of the esophagus still in the intra-abdominal part. This is a very important segment of the esophagus to keep it in patency of the cardia. There is a difference between the pressure and the intra-abdominal pressure. It is a positive one. The intrathoracic pressure, it is a negative pressure. So the difference between the pressure, it keeps the cardia inside the abdominal part. Third one, because it is an oblique insertion of the esophagus to the stomach, it is not a straight one. This is what we call it angle of Hess. This is to keep the patency of the cardia. And also we have a phreno-esophageal ligament. This is a sling-like to keep the esophagus inside the abdomen, and also we have a block-like action of mucosa. It is fold as a cardia, what we call a roseate-like folds. يعني مثل الورد إذا تريد تشوفها مثل الوردة تلقاها هذا بالاندوسكوبيك تشوف الorifices of the cardia. It look like this. And beside that, there is a Pinchcock effect of the right crust of the diaphragm. And the right diaphragm, right diaphragm, right diaphragm. It will become from the crust malta, from the L2, L3. It will be sling around the lower part of the esophagus to keep it inside. And also because the pressure, it is a physiological muscle sphincter of lower esophageal, it is act as a valvular one. The pressure inside this, it reaches to the 25 centimeter of mercury inside the lower esophageal sphincter. It's very important pressure. This is, as you remember it, in the first lecture, the part of the esophagus is cervical part, thoracic one, and abdominal one. Now, there's another esophageal motility disorder, what we call the cricopharyngeal achalasia. If you remember, I told you should be differentiated between cardiac achalasia and here a cricopharyngeal achalasia. That we call it cardiospasm, or we call it the lower part achalasia here, a cricopharyngeal achalasia. You should be differentiated between them. This is in the upper part, that one in the lower part of the esophagus. Or maybe what we have, a whole body spasm. This diffuse spasm. These are, it look like not a cracker, مثل كسرت jaws. It will be appear esophagus. Or maybe there is no pathology, only the hyperperistalsis part of the crest. This is a part of the crest syndrome. Crest, it is there's a calcitosis. R, it is a rhinoid. E, ergot, and S mean scleroderma. T, telangiectasia. This is a part of syndrome of what we call the crest. The hyperperistalsis, this is. And also we have an eosinophilic esophagitis. These are also beside maybe hypertensive lower esophageal sphincter. As I mentioned before, it is 25 millimeter of mercury. It is the pressure. Here in the pressure, it is more than, it will be lead to the, what we call it like achalasia-like. It will be lead to the spasm of lower part of the cardia. Now, another pathology we have, beside the hiatal hernia, we have what we call reflex esophagitis. First of all, you should be differentiated, dear student, between esophageal reflex and reflex esophagitis. What is esophageal reflex? Esophageal reflex, it is a normal physiological phenomena. This is what we can see it in the baby when he took breastfeeding or artificial milk feeding. After that, immediately spill off part of this milk. It looked like a cheese-like appearance. This is what we call it esophageal reflex. Also, we have occur, and in the adult, when he took a heavy meal, especially a fatty meal, and he feel a regurgitation. This is what we call it esophageal reflex. The reflex esophagitis is a pathological one. You should be put it in your mind. This is a normal physiological one. This is a pathological. Esophageal reflex, it is a normal physiological one. Reflex esophagitis is a pathological one. It is produced by reflex peptic juice through the incompetent cardiac sphincter in the lower esophagus. Mean there is acidity to come to the lower part of esophagus. المور risky باباتي هنا الأسيد دي يطلع من السtomach to the lower part of esophagus. The more serious if it is an alkaline, what we call this a biliary reflex. Biliary, the part of the bile come to the stomach and go to the esophagus. This is an alkaline one. This is a more serious than acid one. More acid, it is not affected like more alkaline. So alkaline is more serious than an acid reflex. This is it when they have a reflux to the lower part of esophagus. By the time the mucosa, it would be not stand of this acidity or alkaline, lead to the start of ulceration and inflammation, and eventually it will be lead to the stricture. If you took it in the medical side, I think Dr. Fadel, he mentioned there is a 4 stage of this reflux esophagitis: stage 1, stage 2, stage 3, stage 4, according to the appearance by endoscopic of the lower esophagus, from hyperemic إلى ulceration إلى stenosis and lastly stricture. A degree of the GERD, gastroesophageal reflex, a normal pathology after meal lead to the regurgitation, swallow of air to maintain comfortable. هذا دائما يكون قلنا لكم لما تاكل الهيفي meal, especially in adult one. This is what we call it a transient esophageal sphincter relaxation. This is esophageal reflex, not reflex esophagitis. Now, what is the clinical feature of that reflex esophagitis? We have a recurrent burning pain. This is what we call it in term. When you took a history, this is what we call the heartburn. حرقة عندك يقولوا تسأل المريض عندك حرقة لو ما عندك حرقة. Second, we have an epigastric pain, and also we have a fatty dyspepsia, odynophagia with hot beverage, citrus drink or alcohol, especially when he took a hot beverage or citrus or alcohol, lead to the pain. Odynophagia, it is a pain swallowing, painful swallowing. May be presented as angina-like pain, because of epigastric pain, and return back to the retrosternal. The patient is always coming and seek for medical side in the cardiology because of feeling he look like a pain like angina. Because of this reflex, may be part of the food materials inhalated to the bronchial system lead to the pneumonia. But always the reflex of that one, when we go to the laryngeals, it will be lead to the change of the voice. By the time lead to the hoarseness of voice due to the recurrent reflex esophagitis. This is occur especially when it is lying down flat or in a stooping one. So always you should be advised the patient. When you took a heavy meal or you took any meal, you should be not pray immediately after taking a meal, or you are stooping or knee down. You should be stay at least 2 hours before you do that. So always you should be advised the patient, when you go to the pray, it should be an empty stomach or after eating in 2 hours. Also, if you have to do a knee down, it should be before you took a meal or after you took a meal in 2 hours. How you can diagnose that one? By barium study, endoscopic biopsy to exclude any change of malignancy, by cytology, and by esophageal pH measurement, ambulatory 24 hours pH monitoring, or standard acid reflex test, acid clearing test. This is all in the medical side. I think Dr. Fadel, he mentioned and details about this one. There also esophageal manometry is very important, and radioisotopes scintigraphy. Now, because of this reflex esophagitis, because of the retrosternal pain, because of the fatty meal affected of the sign and symptoms, so we put it maybe a differential diagnosis, maybe due to the cholecystitis, or maybe due to the peptic ulcer, we can put a differential diagnosis. Because of retrosternal pain, maybe you put a differential diagnosis like angina pectoris. Treatment of this reflex esophagitis, and medical and surgical, you should be always advise this patient to take a small repeated meal, not take a heavy meal. It should be keep away from the fatty meal. You should be keep away from alcohol, cigarette, or citrus. لا تقول له بتاكل حمضيات أكثر من اللازم. صح, it is a good in this era because of the COVID-19 to take vitamin C with a lot of them, but not to take so much. Don't take to so much, especially at night. You can take it in the morning or in the daytime, but not at nighttime. Surgical treatment, in which cases we do a surgery. Surgery when there's a failure to control the symptoms with a medical treatment. For how long here we can took a surgery, we decided should be and put it at least the patient he took the 6 weeks of the proper treatment to 3 months, 3 months. And you should be stop the treatment for 3 months. If it is a repeated one, you can repeat the treatment for 3 months also. If it is, and stop it for 3 months, if it is still have complaining, and later on we can do a surgery. And there is an intractable esophagitis complication by hemorrhage or chronic anemia. بقى المريض هنا بدأ complaining of esophagitis, intractable, painful, ما يقدر يتحمل, بدأ hemorrhage, بدأ المريض يكون anemic, sign and symptoms of anemia. This is also indication for the surgery. Esophageal structure, because of difficulty to swallow, this is a difficulty. Maybe you can do by endoscopic dilatation, or you can do a surgery by one. Or we have respiratory complications secondary to the aspiration, or maybe you have a huge hiatus hernia causing a postprandial cardio respiratory distress. Mortality rate of the operation only 0.5%. Failure of operation is only 5 to 10%, but curative operation it is 85%. There is more than 8 types of surgery we can treat it with the esophageal reflux esophagitis, more than 8 types. Another one, this is another important one, the carcinoma of the esophagus. Carcinoma of the esophagus, the incidence is about 20 per 100,000 USA. It is more 160 per 100,000 in UK. It is more than 450 per 100,000 in the Kazakhstan and Iraq, Iran, and South Africa. It is more common, this esophageal tumor, it is in the north of Iraq. Male more than the female, and in age it is older group. What are the causes of this esophageal carcinoma? Environmental. It is a localization in the north of Iraq, in the Kazakhstan, in Iran, in the South Africa, and also in Uzbekistan, in all this area. It is in mountain area. Also because of the local food stuff. أنا اليوم أنا أكل الكين دائما أنا أحب المعلبات. It is always components of the nitrous component. The nitrous component by the time it leads to the esophageal carcinoma. Pickled vegetables المخللات or smoked meat اللحم المدخن ببات it will be increase. تيجي تقول لي ليش انه شمال العراق اكثر من جنوب العراق وهاي لانه by our notice because of the type of the meat. We in the south of the Iraq, in the middle of the Iraq, it is always we eat sheep. بينما in the north of Iraq it is they eat a goat. يحبون الماعز لحم الماعز أكثر من لحم الغنم. يمكن هذا part of it we by statistical we find this is the causes of the esophageal tumor in the north of Iraq and in all the mountain area. Iron deficiency anemia, this is in case of the Plummer-Vinson syndrome. What is the Plummer-Vinson syndrome? Plummer-Vinson syndrome it is in the female and 50 to 40 40 to 50 years of age. It is adulterous, سنونها معكم موجودة, and have anemia. Anemia, it will be iron deficient anemia. We see the spoon-like appearance of the nail. Spoon-like appearance of the nail. يعني طبع على أصابع يديناتها spoon-like appearance. This is, we have cervical dysphagia. cervical dysphagia. These are criteria of the what we call the Blue-Morphin syndromes due to the iron deficiency. If it's not corrected by the iron, later on maybe lead to the structure and lead to the carcinoma. Zinc and molybdenum deficiency also have a part of the causes of the CA esophagus. Smoking, alcohol, also increase the incidence of the esophageal carcinoma. Tylosis. Tylosis is an autosomal dominant disorder. شوف the human papillomavirus and hyperkeratosis of the palm and soles. يعني أول ما تلزم الكف الإيدينات والشعب مالته تلقى لك كيراتوسيس متخشب، يعني وخشنة الإيدينات مالته خشنة زين مثل البسامير اللحمية تلاحظها في إيديناته. This is in case of what you call tylosis. These are the causes of one. What are the pre-malignant؟ يعني شنو هي الأعراض اللي ممكن إنه ممكن المريض يصاب بالأسوفيجيال كارسينوما. When you have a Blue-Morphin syndrome, the achalasia in the cardia it increase 7% than normal individual to be developed of this CA esophagus. Corrosive esophagitis also increase the incidence of the esophageal carcinoma. Begiert gastroesophageal reflux lead to the peptic ulcer and Barrett esophagus. The Barrett esophagus means change of the type of mucosa from normal mucosa to intestinalization of the mucosa. It would look like of the intestine type of mucosa in the lower part of esophagus. It look like an intestine, small bowel. Now, pathology of that one. We have three types of that. Macroscopical, by your eye you can't see it. Annular stenosis of the cardia. It is a circular stenosis of one. Or epitheliomatous ulceration with raised everted edge. Or fungating like cauliflower. And macroscopical is more squamous cell carcinoma. Adenocarcinoma, true to the columnar epithelium lined by lower part of esophagus and the Barrett esophagus, it is an intestinalization of the lower esophageal with dysphagia. And more common, it is our squamous cell carcinoma, but adenocarcinoma now increase more than 60 to 75%. Now it is previously squamous is more. Now it is adenocarcinoma, it is a more. Now adenocarcinoma, it is more than squamous type. The affected site of the tumor, cardia presented about 32%, a lower third of esophagus 25%, يعني mean the lower part of esophagus presented about 55% of incidence. The middle part, 1/3, it is only 32%. The upper part, 3%, which is the worst part. يعني we face it by surgery. And in cervical esophagus, it is 8%. As you know, spread of a tumor, there is a local spread and lymphatic and hematological spread. Local, it will go to the mediastinal structure like trachea and aorta. Lymphatic, it go to the paraesophageal, tracheobronchial, supraclavicular, or subdiaphragmatic lymph node in the celiac area. Bloodstream, it go to the liver and the lung. Now the clinical feature. Now how you can differentiate the clinical feature لما يجيك المريض between cardiac achalasia and CA tumor of the lower part of esophagus. Both of them affected the patient. هنا بالachalasia باباتي, if you compare it to achalasia or CA esophagus lead in the elderly age, بينما بالمقابل بالcardiac achalasia it will be in the middle age. Second, here is more common in the male, بالachalasia and more common in female. Third one, we have a dysphagia. Dysphagia here, it will be different. Here, in CA esophagus, the patient start start difficulty in swallowing of the hard meal, and the achalasia start in the liquid. يعني هنا المريض يقول لك والله أنا عندي صعوبة لما آكل لقم solid meal, it will be affected me. بينما هنا بالأكليزيا يقول لك liquid, it will be affected me. يعني it is easy to take a solid meal. هنا it is easy to take a liquid meal. Fourth thing, by dysphagia, by progress of the time. And the achalasia, because the start of the solid dysphagia, by later on, when an increase in the size of the tumor lead to the complete obstruction, it will be lead to the liquid dysphagia. يعني it will be difficulty to swallow a liquid. بينما هنا start of the liquid بالachalasia, and later on even the يعني solid, it is easy. Later on it will be affected of the solid also. هنا تجي تسوي لك تيست، تسأله للمريض سؤال واحد، تقول له عادة أبو الأكليزيا باباتي when you have by the time experience, when you have a difficulty in the swallowing and have dysphagia start, and in the lower part he said, I have a feeling the bolus of the food it stand in the lower part of the esophagus. يقول لك أنا عندي في اللقمة توقف عندي خلف الاسترنم. So by the time they know, when you have this dysphagia, he stand up. يوقف المريض. لمن يوقف المريض by gravity, by the time in 2 to 3 minutes it will be easy to go because of this bolus, because of the solid food. It will be lead to the pressure on the achalasia, it lead to the relaxation and coming. So he trained always to take a food when he is standing up, not sitting down. Easy. Later on babati, now لما تسأل أبو الأكليزيا, which is a more you prefer, hot water or cold water? He always prefer a hot liquid than cold liquid, because it is easy to swallow it. After that, by investigation, when we do a barium swallow and bill, and the CA esophagus, it will be lower part. It look like red tail appearance with shouldering. هناك, if you remember in the last lecture, it will be appear like bird beak, مثل المنقار الحمام أو الطير. it will be appearance in the barium study. This is how you can differentiate it. لما يجيكم سؤال how you can differentiate it between cardiac achalasia and esophagus, you should be mentioning all this. Second, it will be lead a general manifestation of the tumor lead to the lost weight, anorexia, anemia, كشكسكل بالمريض. By the time if it is an increase of this tumor and lead to the secondary deposition, metastasis to the lymph node in the neck, we have enlargement neck lymph node, or maybe go by hematological, lead to the liver, lead to the hepatomegaly, or maybe lead to the aspiration pneumonia due to the perforation of the esophagus to the trachea, lead to the tracheoesophageal fistula and inhalation pneumonia, or maybe because of the hepatomegaly and affected of the liver lead to the jaundice, and maybe lead to the hoarseness of voice and cough and choking because of the respiratory problem. To complete your investigation by barium swallow and meal, chest X-ray important, and endoscopical biopsy, brush, and cytology to take and to know the type of the tumor and localization of the tumor, and by bronchoscopy to exclude any tracheoesophageal fistula not invading, abdominal ultrasound to see any distant metastasis, and endoluminal ultrasound, transesophageal ultrasound to know the tumor affected only mucosa, submucosa, all the muscles of the esophagus, and CT scan with lastly, laparoscopy to exclude any tumor involving the abdominal organs. This is how it will appear of the tumors. This is by endoscopic, how it will appear the tumor, the appearance of the tumor. And you see it will be radial appearance and shouldering of the esophagus. Now the treatment, the principle of treatment, it is resection of the tumor to relieve of dysphagia, but depend on the tumor size, cell type, meaning grading, degree of the cellularity differentiated, and location. This will be affected the survival and early diagnosis. So either it will have a palliative or a curative. Most of, unlikely in esophagus, we do a palliative surgery, very limited number we can do a curative then because of the delayed, or maybe the patient he refuse the curative one, he want to do a palliative because of heroic surgery and because of old age. Besides, he have comorbidity, hypertensive, ischemic heart disease, diabetic, or renal impairment. This it will be affected. Even the patient he is unfit for GA, for the curative one, or the patient he refused the surgery for the curative one. So we can do, most of them, about 75% we do a palliative. Only 25 to 30% we do a curative one. The curative means we should be resected of the tumor 9 centimeters above the mass and 9 centimeters below the mass to prevent any recurrence of them. Either we do, if we have a lower part, in the cardia, we can do what we call the left thoracoabdominal approach. A lower part of esophagus, we can do a left thoracoabdominal approach. The middle part, we do a two-stage operation. This is what we call the Ivor-Lewis operation. First of all, we do laparotomy and the start of mobilization of stomach and make a stomach like a tube-like. And after that, we open right thoracotomy and complete mobilization of esophagus and resection of esophagus. And we put a stomach inside the thoracic cavity. It looks like a tube. This is what we call the Ivor-Lewis operation, or maybe 3-stage operation, what we call the McQueen. You should be remember these names: the McQueen, the Ivor-Lewis, and left thoracoabdominal approach. This is in the lower part of esophagus. This is in middle part of esophagus. This is in upper part of esophagus. We do a McQueen. McQueen is 3-stage. We can do laparotomy and thoracotomy and cervical incision to pull up of the esophagus through the hiatus. Go either we do it by a 3-stage, or sometimes you can do by 2-stage, only cervical and abdominal. If you have short thoracic gauge and easy, you can mobilization esophagus by your finger from the abdomen, from the neck, and you can pull the stomach to the neck, and resected of the esophagus, and connected the stomach tube-like to the pharynx. Or we can do an interposition, colonic interposition between the stomach and the cervical part of esophagus. We can do it. And also post-operatively, maybe you have a surgery and we have deep X-ray therapy and cytotoxic therapy. 5-year survival following surgery, 25%. 5-year survival following only deep X-ray therapy, 10%. Cytotoxic, it will be lead to the shrinkage of the tumor, 60-20, but not curative. Cytotoxic 5-fluorouracil, cisplatin, you can use it for 7 months. These are the type of the surgery. In the photo, you can see it. How you can mobilization of the esophagus. This is in McQueen, how you can do it from the stomach and from the neck. And this is how you can mobilization of the stomach. And this is how we can resected of the esophagus, and how this is the type we can do a tube like of the stomach. You cut part of this with the esophagus to make a tube like. And this is a colonic interposition, how you can do it. بالماكوين no need to do a 3-stage operation on laparotomy or the neck. You can pull up of the stomach or colon interposition. These are how you can do anastomosis between the stomach and esophagus. These are the procedure we do. This is the colonic, how we can take a colonic interposition. This is how it will be appear of colonic interposition between the stomach and esophagus, cervical one. Or this is a part of palliative. You took a part of a jejunum interposition of the part of the esophagus. This is as a part of palliative one. Now, what is the palliative one? Palliative one, it is when the patient is unfit for general condition, to relieve dysphagia and inoperable. When you have hoarseness of voice, معناته it will be affected the recurrent laryngeal nerve, Horner syndromes, or have persistent spinal pain, mean it will be affected of the spinal cord, paralysis of the diaphragm, معناته affected of phrenic nerve, or we have a fistula formation, tracheoesophageal fistula, it will be unfit and need to the palliative surgery, or we have a malignant pleural effusion. These cases, what we do, palliative might be used بوجينس يعني always أدخل المريض أسوي له dilatation كل فترة يدخل أسوي له dilatation حتى to relieve the dysphagia. Or sometimes you do intubation يعني أخلي لي funnel-like appearance. This is, we have many types of the prosthetic part as a bypass pathway. Either we took it Nottingham or Ankerston Celestine tube or Suter, Proctor, Livingstone. These are a tube like a funnel like, يعني either by pulsion or traction. لو أني أدخلها عن طريق الفم وادفعها بالأسوفيجوسكوب بالريجيد 1 أنزلها إلى البارت of the tumor to bullet. هذا is by pulsion or traction. لا أفتح لابراتومي أفتح الجاستروستومي وأدخل الفانل shape like of the prosthetic pathway. أسحبه من الاستومك إلى أن أخليه إلى منطقة. بعدين I should be cut the lower end of that one, lower end of part one. I close the gastrostomy. I will be closed and laparotomy. This is what we call it, either traction or pulsion, type of insertion of the intubation. أو laser ablation، يعني كل مرة تستعمل أرجون بيم دخلها المريض تكويها المنطقة حتى يقدر يأكل، أو باي electrocoagulation كوتري تستعمل بايبولر not unipolar بايبولر حتى لا يحرق الإنسان. البايبولر يحرق المنطقة فقط بباتي، تحرق التيومر مالته حتى توسع المكان يقدر المريض. أو we can injected الابسوليوت injection، يجي المريض يدخل تحقن له بساعة 12 ساعة ب3 ساعة ب6 ساعة ب9 زين في المناطق الموجودة بباتي. injection of absolute alcohol. It will be lead to sloughing of after 48 hours. It will be slough of this tumor. It lead to the easy to pass of the food materials. Or by sometime insertion brachytherapy, يعني intraluminal radiation, we can put it, but most of center prefer intubation. Or we can do this as an esophageal bypass. The staging of this tumor, يعني only for remember that, يعني not to put it in، يعني only to remember it بباتي. ما مطلوبة منكم يعني stage 1 should be T1 and 0 M0, stage 2 T2 and 0 M0, stage 3 T3 M0 M0, or any T with N1 to N3 M0, stage 4 any T any N any M. ال T يعني tumor size، ال N lymph node، ال M mean metastasis, distant metastasis. This is how it will be appear. Only in the mucosa, submucosal staging, it will be if it affected only the one layer of the muscle, both layer of the muscle, or go out of this layer to the serosa. Resection, يعني it should be no wall penetration, a few lymph node. الهيستولوجيكال جريد it is a well differentiated one. اللوكيشن لما يكون عندك اللور بارت or middle part is better than the upper part. The cervical is good also. The factor make surgical cure unlikely when the tumor greater than 8 centimeter. قلنا احنا لازم نقص 9 سنتيمتر above 9 سنتيمتر below. والاسوفيكس كله هو طوله 25 سنتيمتر. Okay. The abnormal axis of esophagus on barium swallow, a large lymph node on CT scan. The patient was loss of weight more than 20% and loss of appetite. Thank you.